Good afternoon, everyone, and welcome to the CTSNet virtual roundtable on COVID-19. We are going to be talking today about managing to deliver specialist care whilst keeping ourselves safe, and the various precautions that we need to take as clinicians who are exposed on the front line of delivering aerosolizing procedures. So I'm lucky to have with us a esteemed panel today. From a thoracic surgical perspective, we have Mr. Tom Routledge, who's a clinical lead for thoracic surgery at Guy's Hospital in London. I have Dr. Alberto Sandri, who's consultant surgeon at the Ospedale San Luigi Gonzaga Hospital in Turin. Hope I got that right. And from an ENT perspective, this is a very collaborative roundtable. We have Professor Nirmal Kumar, who is President of ENT UK and a consultant ENT surgeon at Wrightington, Wigan and Lee NHS Foundation Trust. And then to just round off the table of interspecialty collaboration, we have Mr. Nigel Mercer, who is President of the Federation of Surgical Specialty Association and a consultant plastic surgeon and past president of the British Association of Plastic and Reconstructive Anaesthetic Surgeons. So thank you everybody for joining us. I thought we'd start by just discussing the general issues that have arisen in managing thoracic surgical patients to start with, and those procedures that we would normally perform without any concern or any second thought, that now we have to really think about in more detail and make up a plan for. So perhaps we start with a UK perspective. Mr. Routledge, do you want to start?
Sure. So I guess our lines of thinking have been on a number of lines. Firstly, we're very aware that we are rendering our patients who are already elderly and comorbid and have cancer, by removing a large part of their lung, we're rendering them probably extremely sensitive or susceptible to severe complications of viral pneumonia. So we are being much more careful about who we offer surgery to, just simply on grounds of the risk-benefit analysis has swung very much more towards the risk side. So we are restricting surgery to those with bulky tumours who will not be well treated by radiotherapy and who really can't wait for surgery. More comorbid patients where the risk of surgery is dramatically higher, we are perhaps advising against surgery, and patients with early stage or indolent disease, we are advising to strongly consider either stereotactic radiotherapy, or most of them are opting for a 2 or 3 month interval CT with a plan for deferred surgery after the viral surge when it's probably going to be safer for them, and also more feasible from a logistic point of view, given our very limited resource to offer elective cancer surgery at the moment. The other side of the coin is obviously staff safety, and the experience of colleagues initially in Italy and now in Spain as well very clearly underlies the increased risk that healthcare workers face, probably because of higher viral exposure, both repeated times and higher overall dose per exposure. And we are adjusting our practice accordingly. Obviously, FFP3 and full face protection is critical throughout any procedure, even relatively minor procedures, chest drain insertion and such. And things like bronchoscopy, which we normally wouldn't have thought twice about, we are cutting back a lot, both awake, flexible bronch and also bronchoscopic surgery, which for us usually means palliation of advanced malignant disease. Clearly, there's a huge risk to staff involved in airway stenting or airway laser procedures, and the benefit to patients in an environment where they can't really get any critical care perioperative support, where they're unlikely to get any other anti-cancer treatment other than possibly palliative radiotherapy, is not clear. So we previously have had quite a big workload of palliative lower airway surgery, which we've cut right back on for that reason.
And Prof. Nirmal, thank you, Mr. Routledge. Prof. Nirmal, can you elucidate a little bit about what ENT's been doing in this field? Because I know you guys have kind of came at the forefront of it very early on and have formulated some guidelines.
Yes. Thank you for that. And that was a good summary from the thoracic perspective in the UK. ENT don't come from that kind of very heavy surgical practice generally in terms of the kind of airway. But our main concern recently in this pandemic has been relatively simple procedures such as nasal endoscopy, for example, or laryngoscopy. And even from those, and we'll be interested to hear the Italian perspective, even from those, and as Tom said, there may be a low but sustained exposure of clinicians and healthcare workers from these aerosols. So that's one big area of concern for us. Of course, the second aspect is the nasal procedures, the surgical procedures on our airway that we, again, did very often for routine clinical conditions such as chronic rhinosinusitis and some tumors. The number of cancers that we did in the nose and the upper airway and perhaps in the larynx is certainly not in volume terms as much as the benign work that we do. But it seems surprisingly that the biggest area of concern for us is in the more high volume but more routine, rather mundane procedures that we have been doing all this time without giving it a second thought, and now have to completely stop and reconsider because these aerosol generating procedures are so dangerous. And it's obviously being shown in Italy and in other countries, but we have also sadly seen that in the UK. And we are in correspondence with Public Health England. I must say they have been very forthcoming in including upper airway ENT procedures as aerosol generating, because in the current guidance, it doesn't state that. Bronchoscopy is there, but not anything else in the upper airway. That's an area of concern. And as Nigel knows, Mr. Mercer knows, we have waited this week for the final recommendations from Public Health England, but they are not yet available. And interestingly, just before I came on air with you all on this meeting, I've been contacted by two European societies, Northern European societies, Norwegian and one more, who say, come on, we are following your lines in terms of what you are saying in ENT UK, but when is Public Health England going to follow? So if there is some good outcome, it is to get Public Health England to recognize the importance of this.
From a societal perspective, I think what's become very clear to me and my colleagues is that the larger bodies, whether they're professional associations or Public Health England or supranational organisations, are not sufficiently agile for their advice to keep up with the rapidly evolving situation. So we've taken the situation into our own hands as coalface specialty doctors and are making our own judgments about risk and our own operational decisions to keep our staff and our patients safe. Because the formalised, multi-committee, political-based guidelines are they're coming out too slowly and they're too out of date.
Absolutely right. And this is what I'm now giving my number freely to every hospital and consultant ENT service lead who wants to contact me, because I'm saying exactly that. We can't wait for more people to die before we actually get this done. Nigel.
I think it's muted.
Sorry. So just to back up what Tom and Nirmal have just said, I've spoken to Derek Alderson, the President of the College of Surgeons of England. We're agreed that in the absence of PHE coming out, and we think it might be tonight, but it probably is going to be very generic, that anyone who's working in an operating theatre should be wearing FFP3 or 2 at the very least, and take full other PPE precautions if they're in that environment. And that is our advice, and I think we will stick to that.
Alberto, is this something that you saw in the early days of the virus hitting the north of Italy? Was there clear guidance from your authorities?
Well, no, we didn't have clear guidance as thoracic surgeons. Of course, there are indications given from our higher Institute of Health and the WHO regarding how to treat patients with all the PPEs necessary, and that's what we're doing. We're strictly following those rules. Of course, as everyone is saying, easy things which we do in our normal practice, like even inserting a chest drain in a patient with a pneumothorax, is becoming really difficult and really dangerous for us and for the patients. So this was probably something which was not so clear in the very beginning of the pandemic in February and beginning of March. Probably this was, I would say, underestimated from all of us. And we had, yes, several actions taken, but too late probably. And if we had more clear indications from our societies and the Higher Institute of Health of Italy, then probably we would have had a better approach to the patient and providing a better service and infecting less people, because unfortunately many of us in the very beginning didn't have these protections and got infected, transmitted the infection to patients without knowing, because they were probably asymptomatic. So this is one of the problems we faced in the very beginning.
Thank you. And to take some specific examples, we were talking about nasal endoscopy. Prof. Nermal, you mentioned that low dose exposure in clinics and such like. Whilst there have been recommendations as to the use of PPE in the operating theatre, a lot of these procedures are performed outside of that setting. And so I just wondered, how have you just stopped doing those procedures in clinic for the time being? How have you dealt with that? Can you hear me?
Hello. Just to connect.
Sorry, Prof. Nermal, how have you been dealing with the nasal endoscopy side of things in clinics in a non-operative theatre environment?
Thank you. I didn't realize this was me. Yes, absolutely. Today I did a suspected cancer clinic, but we really triaged every single patient this morning that I was meant to see. And I would have done about 20% of the patients I would have normally done endoscopy on. And perhaps the only outcome from this pandemic will be that we will treat every such procedure with great respect in future. But anyway, that's for later. But for now, today, we have changed practice almost overnight because of these risks. And we are now looking at each and every endoscopy. Does it have to be done? Is it something that will be either urgent or life-saving? And today, out of the 10 patients that I saw this morning, I did the endoscopy only in 2. Both were in significant cancers and wearing the full protective equipment that I was, fortunately had access to. And I think it's got to be a senior decision. And I'm telling this to all my clinicians in the frontline trainees. If they do any simple thing, even an endoscopy or a drainage of a quinsy, that they need to wear FP3 and not take that lightly, or a treatment of epistaxis. So we've got a whole range of things that we, as you rightly say, we used to do in casual settings in the outpatient clinic, in treatment rooms, but we are now deeming each of these to be high-risk areas, high-risk acute areas. And as Nigel said in the public health guidance, hopefully that will clarify it and we will do it with appropriate protection.
I think your point about senior decision-making is important. And one way to keep our staff and our junior staff safe is to the low-level things that we would all have had our junior staff do without any involvement from us often. I think all of those decisions now need to be made at a very senior level to ensure that we are only doing critically important aerosolizing procedures. And as you say, I've sat in enough meetings with our in-house ENT team, and their experience is the same, is that their current practice is to do a tiny fraction of the kind of office procedures that ENT surgeons do so many of. Reducing it really to the one set of critical, even changing practice of how they're draining quinsies to trying to treat more of them with antibiotics, at least initially, to really minimize the number of high-risk procedures that are being done. So in thoracic surgery, our treatment, we have a high-volume practice in treating elective pneumothoraces and low-level empyemas, and we've moved almost completely to a non-operative treatment of these conditions, at least for now. It may be a somewhat less effective treatment, but the price of massive staff exposure and also using up hospital resource enormously, has to be borne into consideration.
Faraz, do you want to, from a thoracic surgical perspective, the question of ambulatory chest drains and people going home with Portex bags, or people in the community with Portex bags, drain removals in clinic, that kind of thing, how are you guys dealing with that?
So chest drains generally are an interesting topic for us. I've had some correspondence with Medela, who make the Topaz digital drains that are widely used in thoracic units across Europe. They have a little electrical pump that sucks air out of the patient, pulls it through a filter, and then exhausts it through the back of the drain. The filter is rated as a bacterial filter. It's not rated as a viral filter. Medela are very keen to imply that their drains are probably the safest option currently for inpatient and potentially outpatient use, but I'm not convinced. Our take at the moment is probably the safest option for all concerned is a straightforward underwater seal, but connected to wall suction, so that there is no evacuated air, which presumably is rich in virus, being blasted into the patient's immediate bedside area. I'm not fully clear what happens to the air when it goes into a hospital wall suction unit. Whether it, I don't know whether it just shoots out of the side of the hospital or whether it's in any way treated before that happens. I've asked our works department to clarify that, but at least it's not spraying around the ward. So our view on inpatient drains at the moment is that probably the safest thing is to have them connected to hospital wall suction. So it's a closed circuit. Other people believe that the digital drains are safer at the moment. I'm really not convinced that that's the case. What is clear is that valved chest drain bags are really not safe. It's fine in a patient's own home, but in a hospital ward or even traveling back home, that seems like a dangerous option.
May I just add on to our chest drains in Italy? We use a water seal drain. Of course, we have Topaz Medelas in our ward, and I believe those are the safest ones. But still, we do not know whether they filter. I mean, the filter works with the virus or not. However, we use these water seal drainage systems, which do have actually, I mean, they are a closed drain, but still some air comes out of the drainage system. So unfortunately, we had to think of something homemade in order to protect the system itself and avoiding the spread of this air coming out from the chest of the infected patient. So we just wrap them around some transparent plastic bags and tape them to the tube. I know it's silly to look at it, but it's cheap, it's cost effective, and it works. That was one of our main concerns here, especially in our ICUs.
Alberto, can I ask, have you seen a lot of pneumothorax related to the ARDS from viral pneumonia?
Yes, we did. I can count at least 4 of them, which needed a drain, and we had 3 cases of pneumomygestinum, which we cannot relate to just a positive pressure like CPAP. Because some papers have been published on this as well. I think it's related to the viral problem itself. We had to drain patients, of course, and that's a nightmare. You have to dress up with all the PPEs possible and available, take care. And as you said earlier on, these procedures, although they're very basic in our daily practice, need to be rethought, and our junior fellows and residents are not allowed to do those procedures in order to avoid complications, in order to preserve as many PPEs as possible since we are in shortage of them. And one more protocol which we added on after chest drain is that, especially in intubated patients, that we don't pull out the drain until the patient is extubated. This is something which may sound odd sometimes because, you know, the lung may be expanded and there's no air leak after 3-4 days of suction, but still we don't want to risk a re-drainage, which already happened once in the very beginning in such patients. This obviously in taking care of the PPEs available, and you know, it's something which we thought would improve our practice.
That sounds very sensible to me. Another area of ITU chest drain practice that we've seen a bit of, and sadly anticipate seeing a lot more of, is intubation-related major airway injury. Clearly, you know, intubation has been carried out under challenging circumstances in huge numbers by teams wearing unfamiliar kit, and probably increasingly in the UK by, as things get bad, by teams who are perhaps less experienced. And we've already seen 2 or 3 major tracheal lacerations from intubation in southeast London over the last few days. And so we're drawing up a non-operative protocol to our ITU colleagues manage these in the first instance, essentially bilateral chest drains and advancing the endotracheal tube as far as possible so that you're distal to the injury. Normally we would do that under bronchoscopic guidance, but given the concerns about bronchoscopy, we're going to advise blind advancement of the endotracheal tube and then checking its position with the chest X-ray to make sure it hasn't gone too far in. But sadly, I suspect we'll see a reasonable number of major airway injuries.
Yeah. We had one in our hospital and one referral from another hospital, and we dealt with it the same way you did.
Moving on from that side of things, another cross-specialty issue, I guess, is that of tracheostomies. Two specific points. One, the first being tracheostomy in COVID-positive patients. So COVID-positive patients who've been on a ventilator for a long time. From a ventilatory weaning perspective, I know it's something that's been discussed that probably isn't happening very much. And then the second point is those patients who have trachees, who have tracheostomas, maybe mature stomas that are long-standing, how we manage those patients in the outpatient and the inpatient environment. So maybe Prof. Nirmal, if you want to take that.
Thank you. It is certainly at the forefront of our mind, the very point that the first one that you just raised. I'll be interested to hear the Italian perspective, but we quite early on, ENT UK have been very active in drawing up guidelines which we have put up on our website and circulated to our members. And we are very conscious that, first of all, tracheostomy is a high risk. That was already there in the old PHE guidelines. But the timing is something that is increasingly of concern, because the standard teaching, of course, we have all practiced in the past, was to do it fairly soon to help in the weaning. But there is concern from many colleagues around the country that we shouldn't do this too soon. Really interested to hear the Italian view on that. And today, a group of us who wrote the first draft of our tracheostomy guidelines for COVID-positive patients, we are going to revise it because we are getting pressure from intensivists in ICUs around the country to do this fairly soon. Our view is, and the group has not yet finalized, we need to consider percutaneous tracheostomies in the first instance, and then open surgical tracheostomies only if that is not possible for whatever reason. So that's the first one. Timing-wise, certainly not the old timing in terms of the how soon we do it. Shall I invite the Italian perspective on that in terms of the timing before I answer your second point?
Alberto, have you been involved in tracheostomy care in Italy, or are you aware of what the policies be right now?
No, unfortunately, we don't do them. It's not a procedure that we do on a daily basis. It's the ENTs doing it, and I don't have any experience in that right now, so I can't help you with that.
Okay, I think, yes, timing-wise, it is something that we will have to consider carefully. And the feeling is not too soon. And the old stories about, causing subglottic stenosis and problems like that perhaps don't hold good. And sorry, what was your second one, Leanne?
So from a second perspective, those patients with existing tracheostomies.
Yeah, the management, yes, that is certainly an area that we will need to consider carefully, because managing these patients, even changing a tracheostomy tube, if they have had a laryngectomy, to change their speaking valves, all these are, we are classifying as aerosol generating procedures, and therefore we will need to wear the appropriate protective equipment. And even changing a tube need not happen unless it was absolutely essential. And our protocols are being sort of looked at very carefully. We have obviously not yet come to the stage where, for the COVID positive patients, we have not done too many tracheostomies. Only today I was sent in my neighboring hospital their first COVID positive tracheostomy, and how they managed it. They put a little set of recommendations which I'm going to circulate. In London, perhaps you may know, Tom, how many and how.
I've certainly sat in discussions. I share a directorate with our ENT surgeons, so I've sat in on a lot of their discussions. Again, the view is tracheostomy should be deferred as long as possible. If it's for respiratory weaning on the tail end of an ARDS process, the hope is that many of these patients may have become virus negative, or at least much lower viral load, if you leave it as long as possible. Obviously there's a lot of concern about carrying out the procedure itself, but actually it's felt that can be done fairly safely as long as you essentially make the patient apneic for the entire period, which again means somebody needs to be well down the recovery pathway so they can tolerate periods of apnea, so you're not blasting contaminated air into the operator's face. A major concern in London, if we are too generous with the number of patients we tracheostomize, is that tracheostomy care nurses will be a critically short resource. You can send an ENT team around, putting in hundreds of tracheostomies here, there, and everywhere. But if there are no specialist nurses on the step down wards to look after them, then that's a really big problem. So we are trying to upskill other nurses in basics of tracheostomy care. But I think you're right. I think the key is leaving tracheostomy insertion as late as possible and doing it in as few patients as possible, and not reaching for that as a procedure as early in the respiratory recovery pathway as you normally would.
Yeah, I think Nigel.
Can I ask a question on that? So what's clearly happening here is there's very significant changes in practice, both from the intensivist point of view and from the surgical point of view. And the bit that Tom mentioned about rendering the patient apneic, I hadn't thought about, nor would I. That type of information, which you have obviously learned from Italy and from Wuhan through harsh experience, how is that sort of information being promulgated around the thoracic and ENT and the intensive community? Because hopefully it is.
At the moment, for me, it's operationally within our own hospital and with our own teams. ENT UK, I think, probably have been a bit better and more centralised approach than the UK thoracic community. And I know there's, even within London, there is quite a lot of varying practice and varying awareness of the risks involved.
One of the things the FSSA has is that we have a close link with the Association of Anaesthetists. So we can promulgate information like that extremely easily, as long as it's agreed by the specialty societies that are involved. So that's just an offer. That's something we can do very easily.
I think ENT have been very good. For tragic reasons, the risks were highlighted to that community very early on. I think the thoracic surgical community have been more varied in their appreciation of these factors, and I think some help in agreeing and disseminating an awareness of risks and how to change practice would be very helpful.
Thank you.
Thank you.
That was part one, and thank you. We'll be back with part two shortly.
Thank you.